Welcome to the American Shoulder and Elbow Surgeons Podcast. I am your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City, and I'm joined today by my co-host, Rachel Frank, a sports and shoulder surgeon at the University of Colorado in Denver. Rachel, how are you?
Doing well, thank you very much. How are you?
Doing great. Before we get started, I should mention that the views expressed in this podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, the University of Colorado, or the institutions of any of our guests. Today, we have the supreme fortune to be joined by Professor Pascal Boileau. Many of our listeners will know Professor Boileau, but I'd like to briefly introduce him. Professor Boileau is the head of the Department of Orthopedic Surgery and Traumatology at Pasteur II Hospital, also known as CHU Nice, in Nice, France. He came to Nice after completing a fellowship with Professor de Jour in Lyon and completing a traveling fellowship in the U.S. through Sofcott and CESEC. He serves in multiple roles at CHU Nice, including the Vice Dean of Research, the head of the University Institute of Locomotion and Sport, the head of outpatient surgery, and a member of the Executive Council. He served as the president of CESEC and has too many awards to count, including the Neer Award. He's been a pioneer and innovator within our field for decades, and his contributions include the design of the Equalis implant, his technique for the arthroscopic Latarjet, and countless others. He's published over 300 articles and has been to nearly 500 conferences and is an invited speaker. He has been the chair of the Nice Shoulder Course since 2003, which is attended by over 600 shoulder surgeons from all over the world and is internationally recognized as one of the best meetings a shoulder surgeon can attend. On a personal level, I can say that the time I spent with Professor Boileau, when he was kind enough to have me as a visiting fellow, was among the most transformative periods of my thinking about the shoulder. Professor Boileau, welcome to the podcast.
Thank you very much, Peter, for this very kind introduction, and hello to Rachel as well. I mean, I'm very pleased to be with you today, and I hope we will have a chance to speak about the new format of the Nice Shoulder Course.
So, Professor Boileau, I've wanted to have you on the podcast for a long time, but now is a particularly propitious time because I know that right now the Nice Shoulder Course, which requires years of preparation, and as you were closing in on the finish line for 2020, COVID-19 hit, and you've had to make this huge transition to virtual. So tell us, how has this transition impacted your planning for the meeting?
Yeah, you're perfectly right. I mean, as you know, this meeting occurs every other year, and we were almost ready because the initial dates for this meeting was June 4, 5, 6. And then in March, the country here was hit by the COVID, as everywhere in the world. And at first, I wait for a few weeks to see if things could be better. But unfortunately, things didn't get better. So I had to take the decision. So the first decision that I took was to postpone the course to early July. But then after a few weeks, we realized that we will not be able to do the course in his traditional format because of nobody would be able to travel. And so that's I had two options. One was to just abandon and to make it next year, but next year normally it's ANSI meeting, so it would be a pity. And to be in competition with the ANSI meeting with Laurent Lafosse, we always try to make ANSI 1 year and Nice the other year. And there is also the Paris meeting, and there are too many meetings next year, so it was not possibility to postpone to next year. 2 years from now was too far away, and the program was done. The speakers were okay; they were ready. There were many very interesting topics, so I took the decision to try to organize the Nice Shoulder Course in a new format, which is a virtual meeting, but a virtual and interactive meeting, because our goal was really that people would be able to participate. We didn't want to do just a classical webinar. We wanted to really do a meeting where people could interfere, ask questions, participate almost live. That's the story of this new format for the Nice Shoulder Course.
Well, thank you for that. And Professor Boileau, we know that the Nice course is famous for its live surgery, which is incredibly educational for everyone attending. And I think one of the highlights of the meeting, it's performed with surgeon moderators. How are you going to replicate this virtually? Are you still going to have moderators? And if so, how will that work?
Of course. So we could not we could not organize real live surgery because we didn't know if we would be able to operate and to recruit the patients at the time of the meeting. So we have organized real live surgery. So it's going to be a format of 20 minutes for the surgery, which is enough time to comment the important steps of the procedure. And then there will be, in the meantime, the surgeon will comment the video, the real life surgery, and will be able at the same time to answer to the questions from the web. So altogether, it's 30 minutes plus 10 minutes at the end to answer really the questions or to debate with the moderators. So it should be a very interesting format. For instance, Laurent Lafosse will demonstrate again his technique with arthroscopic Latarjet, and he will be able to show all the tips and tricks and all the difficulties that he had to face and that he has solved, and people will be able to interfere and to ask questions as well as the moderators for this session of live surgery. There will be many others live surgery. Marcus Scheibel, for instance, will demonstrate how to do an arthroscopic AC joint repair for acute and chronic cases. Mark Frankel will demonstrate how to do a reverse prosthesis with his technique. Joaquim Sanchez Sotelo will show us how to do APC prosthesis. I mean, prosthesis composite reverse prosthesis for bone loss, human bone loss. So many very interesting topics. Jean Cagny will show us how to do an arthroscopic latissimus dorsi transfer. So there are many options for the people who would like to attend this meeting, this virtual meeting.
Well, certainly it sounds like you guys are going to have a great number of different live surgeries. Certainly that lineup sounds incredibly intriguing to me. And it sounds like you've worked hard to still involve time for discussion. When I attended the Nice Shoulder course, one of the things that I found the most fascinating was you had many roundtable discussions. We'd have a controversial topic, international experts, and then there would be a discussion. And there's always, of course, disagreement. Maybe a case discussion. How are you planning to replicate that virtually?
That's a good question. First of all, I have almost tried to make short talks and to keep enough time for the discussion and controversies. And it's true that in Europe we are more controversial than in the US, for instance, where everybody try to be very kind on the podium. Here in Europe, people sometimes are a little more, I would say, aggressive, but it's a kind of aggression. I mean, it's not something bad, but at least it pushes the people, the speakers, the surgeons to really tell the truth, and that's why we like this format. So we will try to do the same, and it all depends on the choice of the chairman or chairwoman, and it all depends on the balance between the speakers that you put, the topics that you put, and the chairmen that you choose for this kind of debate. But I mean, we will try to replicate this, although it's virtual, and because this will be live. I mean, the discussion and the question will be live. Actually, the format is that what we have chosen to do is that we could not do the entire meeting during 3 days on the net. It would be too long. Nobody would stay hours in front of the the computer, looking at or listening at that. So what we decided is that we would do 5 hours of live session, and we choose to do this between 12 a.m. and 5 p.m. because this gives the possibility for all America, North and South America, to be present. It's early in the morning, and it allows as well all the people from Asia to be present because it's late in the evening or early. It's late in the afternoon or early in the evening on the east side of the world. So the 5 hours will be between 2 a.m. and 5 p.m. French time, and it will be early in the morning in USA, in Argentina, Brazil, and late evening, late afternoon and evening in Asia. So normally people will be able to be present, and they will be able to ask questions through the web to the participants, and the chairman have accepted to be present during these 3 days for 5 hours if they are on the podium for a real life surgery or for a symposium or for a case clinical discussions. You have to make the balance between the moderators. And for instance, when you have someone like Christian Gerber as a moderator, this is sure that there will be some debates because he is very good at pushing people on their boundaries.
Well, it certainly sounds like you're doing everything possible to create an atmosphere for great debate, and I think it's nice that you're thinking about not just the population in Europe being able to attend the meeting even virtually, but also around the world, and trying to accommodate different times that might work for the most people. So that's really thoughtful, and I think the attendees of the course will really appreciate that. One of the aspects of every major meeting has been the involvement of industry to help fund the educational efforts, and with any virtual meeting, we're sure that this has been a major challenge. And the transition with a virtual meeting certainly is financial because it costs money to use the platforms and to put on such a meeting. How has the transition to a virtual platform influenced the involvement of industry, not necessarily with this meeting in particular, but how do you see this influencing meetings in the future?
So it's a very good question, because at first I was worried that the industry partners will not participate to this kind of meetings because they will not be interested. But we have to realize that actually, if they don't participate to this kind of meeting, they don't get access to the surgeons, or it's very difficult for them to get access to the surgeons and to present their portfolio, their new implants. And so finally, I was very happy to see that most of the companies, not all, but most of them, at least many of them, did accept to participate to the niche shoulder course, to the virtual niche shoulder course. And the reason is that we have tried to make them happy by providing them a platform. And I want to talk about that. We do this with a company called BMed, and BMed has built all the environment, the virtual environment of this meeting, and they built a platform for the industry, so the industry will be able to make their own workshops. They will be able to organize their own webinars, and we encourage them to do that. We encourage also the surgeons who work with some companies to stimulate the companies to tell them to participate to the NIST course, because there will be room for that, there will be time for that, and there will be a very good possibility to show their products. And as you know, the NIST shoulder course actually is going to be the only, probably the only shoulder meeting until the end of the year, if the situation is not better. So it's a good opportunity for them to be present, to still show that they are still alive, that they are still working, trying to provide the best instrumentations, the best implants for surgeons, and to promote their key opinion leaders so that they can do webinars and these kind of things. So again, I want to thank the industry, and I think for those who have not decided yet to participate, it's still possible to do it.
Well, certainly it sounds like it's going to be a great meeting. I think one of the reasons why this is so interesting is because this may, we have a lot of meetings that will probably transition to virtual, and it sounds like some of the lessons you've learned as you've tried to work out how to make that transition have been that some parts of it probably should still be live so we can still have discussion, and that involves working through timetables and figuring out what time is it in different places for people that may want to participate live. And I certainly appreciate all the thought it sounds like you've put into it. One of the great aspects of a transition to virtual is that more people theoretically could attend without having to make that trip. So for our listeners who might not have otherwise been able to make the trip but might enjoy the content virtually, what are the details if they wanted to sign up for this meeting?
So it's very simple. They go on the web and they look for Nice shoulder course .com and they can directly register. And what is important is that the price is very low, especially for the young surgeon. It's only 150 euros. It's 450 euros for the surgeons, senior surgeons. But I mean, for this price, they get the 3 days of live meetings, with 5 hours each day, and they get access to all the other talks, we call these talks on demand, because there are many, many very nice talks recorded by speakers while they present their work, and this will be accessible to all the participants until of December. This will be accessible to these people, to these participants, to these surgeons, and it's a nice way to keep be informed and to continue to study, because you can, for instance, listen to Gilles Valch, to many surgeons giving talks, and which are recorded and that you can access when you register for this meeting.
And Professor Boileau, you've been running this course for 17 years now, and so this next question might be a little challenging just given all the memories. But can you tell us a favorite memory or two from the course over the last 17 years?
Yeah, there are many. I mean, the nice thing about this course, first of all, is that it's international. So, for instance, last time we had more than 900 participants from 65 countries, if I remember. And so seeing these people coming from all over the world and sharing their knowledge, and so it's the good atmosphere that I've tried to give to this course is that it allows to see old friends and to make new friends. But if I can remember one good memory, it's for instance Buzz Burkhead singing and dancing with the Brazilian dancers on in a restaurant on the beach in Nice after the meeting, and it was really completely crazy but very funny. I mean, as you know, Buzz Burkhead is a very good singer, and it was really fun because everybody was dancing with him at the end of the party. So that's one of the souvenirs that I can share with you.
That's a truly amazing story. I have to imagine that live surgery can also be unpredictable. I know you've done a lot of live surgeries for the meeting over the years. Can you tell us a story of a time when things went not quite exactly as the surgeon has anticipated and how your team maybe addressed those challenges?
Yes, live surgery is always challenging because of possible technical problems, because of possible surgical problems as well. Because the surgeons who operate are not at home, so it's not easy to do. But usually we don't have problem. Gary Gassman has operated in Nice. Of course, Laurent Lafosse, Gilles Valch, many surgeons have operated, and these guys are very good, first of all, but they are very quiet. And if there is any problems, they can manage, and we are here with them to help to manage. No, there is no real problem that we have to face. We have been trying to be very accurate with time because it's important to stay in time. But I mean, all the surgery went well, and there was no. I don't remember any problem with this kind of surgery. There is a debate actually in France. I don't know if it's like this, but some surgeons say that live surgery is not acceptable, that it should not be done. Personally, I do believe that it should be continued because it's a good way to really show what you're doing and to teach surgeons. I mean, we never take any risk for the patient. The patient accept the deal. I mean, to be filmed during the surgery, and I mean, and anyway, the surgeons who is in place, in this case myself, I take care of these patients because I'm with the surgeon who is operating, and I will of course make sure that everything will go fine after the surgery. So I mean, all the everything is done like for a normal patient, and the fact that it's done live it doesn't change anything. The patient are still very well treated, like they would be normally. I mean.
Yeah, certainly. I think that it's a great thing for a meeting educationally. So I couldn't agree with you more that it's something that's very valuable as an attendee to the meeting. I can tell you for the shoulder course that my partner runs here, the advanced shoulder arthroplasty course, they looked into this. Could we have surgeons come here to the University of Utah? And we were not able to get surgeons' privileges here, and are from a medical legal liability perspective in the United States, I think there are too many challenges, which I think is a shame because I'm sure that surgeons would come and do a great job taking care of patients. And I think there are patients that would be fine with that. But again, maybe we have a different environment here that doesn't allow us to do something that you're doing there that I think is probably really valuable for all the people who attend your meeting. But I think that's a shame in this country, to be honest.
Yeah, but and you're right, and as I told you, there is a debate actually going on in Europe and in France, especially about the possibility to discontinue this kind of live surgery. But fortunately, the French Orthopedic Society has taken over this problem, and they have made sure that this will be able to continue, at least in France.
I certainly hope that continues and they don't vote or decide to cancel that. I remember my first live surgery meeting experience, and as a young surgeon, I was a resident at the time. It was not only incredibly inspiring to see the surgeons with such confidence to be able to do this and do it well under a little bit more potential pressure. Although I think everyone treats all patients the same, and so you want to treat them whether you're doing it live or doing it on a regular OR day. But just incredibly inspiring to see what surgeons can do at that level and execute technically perfectly, and also stay on time, as you said, which can sometimes be difficult if you get bleeding or get problems with anesthesia or any other complication, let alone the language barrier. So yeah, I agree. I hope that this continues, and it would be great one day to have this in the US. But if not, we'll just have to continue attending the meeting either live or watching via the virtual format. As we transition a little bit away from discussing the meeting, one thing that both Peter and I certainly recognize, but I'm sure everyone in shoulder surgery and really orthopedics recognizes, is that you've been an incredible innovator in our field. Just incredible. I mean, the things Pete mentioned at the beginning are only a few of your accomplishments and innovations within shoulder surgery. What has been your source of inspiration? What kind of gets you started and going with all of this, and what continues to inspire you?
First of all, I think there is some genetic that you have, and I'm used to say that my grandfather was a carpenter, my father was a butcher, so I could be only an orthopedic surgeon. So that's the first thing that I can say, that I have seen my father working. I have seen my grandfather working with wood. My father working also in different fields. But I mean, so I've been used to to do that, to help them, to work with them as a child, and that's the first thing. So it gives you idea to innovate. It gives you, and then the other thing is that when we started with the shoulder, we were really, in a new area which was not explored. So it was just fascinating because when I joined Gilles Valchignon, the shoulder surgery here in France was really in the early years. We were late compared to the USA. In the USA, you had already had the big names like De Palma, Cartereau, Charles Neers, Kahneman, of course. But here in France, the level of surgery was lower for the shoulder, and the levels of technology also was much lower. I mean, the only prosthesis that exists at that time was the near prosthesis. And there was some French and European prosthesis, but not working very well. Arthroscopy was really beginning and very in the early stage here in France, where it was more advanced in the USA. So when we started, it was like going in the jungle and trying to make a path through all the vegetation there, and it was just fascinating to try to find solutions. Also, the arthroscopy helped us to discover the pathology. The arthroscope is just putting an eye inside the shoulder and looking what's going on there, and try to relate the symptoms, the clinics, the clinical examination with what we were finding inside the shoulder. So it was really an area of finding all these things. Now we have to face also. We have to find solutions for solving some problems. Of course, instability, but cuff repairs. Can you imagine that when I started arthroscopic surgery, anchors did not exist. I mean, the first anchors, metallic anchors from Mytech, the G2, came in the early 90s. So it's 30 years ago, but it's not so far away. And for instance, the first stabilization procedure that we were doing was Kaspari technique or the Morgan technique, which means we were using transglenulate sutures to fix the labrum and the capsule. We didn't have any anchors at that time. It seems crazy, but it's true. So, and also for the arthroplasty, I mean, we were very early in the stage, and we could not reproduce the anatomy. That's why we work on this subject. And then came the reverse prosthesis also, which was a kind of revolution that we have to explore to validate, because Paul Gramont, in fact, died too early to validate himself this concept, and this is what we try to do here in Europe. So it was a very exciting travel that we made through the shoulders, and I'm still, as you can see, I'm still passionate, and I'm still happy to do what I'm doing, because every day I'm still learning.
When I came to visit you, you gave me some advice that was actually really impactful on my thinking on how to be a good surgeon and how to be a leader in the field. One of the purposes of the podcast is to try and engage young members of the ASES. My hope is that you could share some of that advice. What advice would you give to a young surgeon who may be listening to this podcast about how to be a good doctor, how to contribute to the field, and how to maybe experience some of the success you've experienced?
So, what I could say that to be a good doctor, you must stay a good doctor. You must not at all become a technician. I think what I try to teach to my fellows, to my residents, is that when you started in medical school, what do you want to be? You want to be a doctor. So today, stay a doctor. It means don't try to become a technician, because politicians, administrators push you to become a technician, because a technician can be replaced by another technician. However, a doctor cannot be replaced by another doctor. Each doctor has his own power, This is called the medical power. This exists. It means that patients respect you. And if you want that patients respect you, you must treat them well. You must treat them as anybody of your family, first of all. And then you should not be concentrate on the technique. I mean, the technique is the easiest part to get. You know, it's level one. I mean, there are two other parts, which are the tactic and the strategy. And as I used to say, surgery is the only job, you know, where you need three major qualities in the same person. In the army, they have three different persons to do that. They have the simple soldier, which is a level one technician. They have the colonel, which is doing the technique, it's level two. And they have the general, which is doing the strategy, the decision. In surgery, the surgeon must be the three persons in one. It means you should be a strategist. You should decide at the clinics if you are going to operate these patients, yes or no. And if you don't, you have to explain why. And if you do, you have to also explain why and the risk that you are going to take together. And you have to explain how you are going to avoid the risk, etc. Then you have to become, you have to be a tactician. You have to explain how you are going to do this operation and why, again, which approach and why. And finally, you have to be a technician, which means a simple soldier, but that's the easy part. And I think the most of the surgeons don't realize that. We should not stay level one, which means a simple technician, but being a colonel and a general at the same time. And I think this is very exciting because there is no other job like this, you know.
Certainly an aspect of life right now that has impacted surgeons, not just young surgeons, but surgeons at all stages in their career is the COVID-19 pandemic, of course. In the US and around the world, as we all know, elective surgeries were put on hold for a prolonged period of time and now are gradually starting to ramp up in most practices and universities and hospitals. How are things for you in France right now? And what do you predict moving forward in your practice over the next few months from a clinical perspective?
So elective surgery has started again, but it's very slow. I mean, actually, the administration does not allow us to do our regular amount of cases that we are used to do. They are still expected a second wave, but I mean, this should not, based on what I know, this should not happen. So it's very difficult at the moment to operate like we were used to do. For instance, in my department, we have cancelled 1,000 patients in the 2.5 months of the COVID period, and we have a lot of difficulties to try to schedule their procedures because we have no slot, you know, in the program, and I think it will take many months before we will be able to come back to a normal situation. That's one point. The other point is that this on the positive side, this COVID has pushed us to be more innovative regarding the way we do the clinics. You know, we can do clinics through the computer, at least for the patient that have been operated. And there are many things that we can improve. And the positive side of this pandemic is that it has just pushed us to do a better job and to use all the modern tools that we have with the computers, you know.
Well, Professor Boileau, I can't tell you how much I appreciate you taking some time to speak with us about your meeting and about your career and your experiences. I know that right now is a very busy time for you, and I appreciate you taking a little bit of time with us. Personal thank you from me to you for everything, you know, for your willingness to have me visit, and then also for your support since then, and for the work we've been able to do together. I'm also thankful from the perspective of the ASES that you were willing to come on our podcast, because certainly I think our listeners will be very curious to hear everything you shared with us today. So thank you from our perspective. I really appreciate it.
Thanks to both of you, and thanks to all my American friends. I mean, all the surgeons at the ASES. we're going to miss the meeting, and I think we will have a chance to meet in person soon, and to be able to shake our hands and to give a hug together. And thank you very much for this kind interview.
What a thought to be able to shake hands again. I know we all can't wait for that opportunity to get back to a little bit of sense of normal, have that next meeting where we can interact in person. And but until then, we'll have to enjoy the virtual format of your meeting and others, and get used to this new normal, so to speak. And at that point, this is about all the time we have for this podcast. We want to thank our guest, Professor Boileau, so much for taking the time to be here with us. And for all of our shoulder and elbow listeners out there, please don't forget to subscribe. For Peter Chalmers, I'm Rachel Frank, and we'll see you next time.